Hello, everyone. We're Group 9, and today we're going to talk about our coupled wearable TSH sensor and levothyroxine pump design. So listed here is an outline of what we will be talking about. First, we will go over the clinical significance. Then we will include some background information on hypothyroidism. Next, we will introduce our design. Then we will talk about the engineering criteria of our design. And finally, explain our assays and experiments. So first, we'll talk about the clinical significance. So there are about 3 million cases of hypothyroidism across the United States alone. Patients with hypothyroidism cannot effectively produce their own thyroxine hormone, which impacts brain development, digestion, bone support, and heart and muscle function. So the drug levothyroxine is essentially a replacement hormone that will enter multiple cell types of the body to influence both transcription and cell metabolism. So current competing treatments like traveling to a clinic for a daily injection is especially inconvenient, and oral tablets have fixed dosages and really have no way of measuring TSH levels within the body. Keeping the drawbacks of the current treatments in mind, there's a need for a new device that is 1, minimally invasive, 2, more convenient for the patients, and 3, has the ability to actively measure TSH levels in the patient's body.
And now we will discuss what hypothyroidism is and what the current treatments are. Hypothyroidism is a disease known as having an underactive thyroid. In other words, it is a condition where the thyroid gland is unable to produce enough of the thyroid hormone thyroxine, also known as T4. On this slide, you can see the normal sequence of events leading to T4 production. When the thyroid is functioning normally, it produces the thyroid hormones T3 and T4 in response to thyroid stimulating hormone TSH. T3 and T4 are then secreted into the blood and delivered to tissues around the body. The current treatment available for hypothyroidism is levothyroxine. It replaces the T4 that is normally produced by the thyroid. The current clinical therapies to treat hypothyroidism are through prescribed oral levothyroxine tablets or through a daily injection of levothyroxine. However, both of these methods have their limitations. For the oral tablets, patients have to take a fixed dosage, which cannot measure their TSH levels. TSH levels are important because if there is an abundance of TSH in the body, that means that there is not enough either T4 or levothyroxine. Daily injections of levothyroxine can only be administered in a clinical setting, and going to the clinic every day is inconvenient for the patient. The patient may also experience discomfort due to being injected with a needle every day.
So now we will go over our design and its components. So our 2-part design has a TSH sensor that will inform the levothyroxine pump of the suggested dosage. The user confirms the dosage and the levothyroxine will be dispensed. The possible dosage maximum and minimum will be present by a doctor based on the patient's needs. This will minimize under or overdosing caused by potential patient error. The pump will handle the signal from the TSH sensor for dosing and will remind the user to also replace the needles, batteries, and tubings of both the sensor and pump when necessary. This design is minimally invasive, does not encumber the wearer, and includes important alerts for patient ease of use.
For each of the major components that will be in direct contact with the patient, we have chosen the following materials. 316L stainless steel will be the needle material for both the pump and TSH sensor. It will stay in the body for up to 1 month and has high corrosion resistance and strength. The pump tubing will be medical grade PVC. This will be replaced after a week of continual use and no toxic particles will be released under this time period. Lastly, a silicone-based adhesive will secure the infusion site to the patient. This adhesive is non-toxic, has high adhesion properties, and in most cases does not elicit a sensitivity response. The main advantages of our system are convenience and portability, providing a new treatment option, custom dosage, and an early warning system. With our device, the patient avoids daily trips to a clinic for injection or avoids oral intake of multiple tablets each day. It also provides an alternative treatment method for patients with malabsorption or gastrointestinal problems whose only option is the injectable form of levothyroxine. The TSH sensor is able to give a custom dosage based on the need of the patient after metabolism of a previous dose or other factors. It could be a potential warning system to the patient if their needed dosage changes drastically and could indicate that a trip to the doctor for a dose adjustment is necessary. Moving forward, we will now discuss the engineering criteria of our device. After the initial application of the device and insertion of the needles, there would be a localized response at the dermal level that includes cytokine, chemokine, and growth factor release and accumulation. This would result in inflammation at the site of the insertion. After the first dose, the levothyroxine will move to all necessary tissues via the bloodstream. This would normalize cell metabolism and balance TSH levels over time. For the mechanical considerations of our design, the needle would be a 20 gauge and about 20 millimeters in length. There has been risk associated with needle breakage at infusion sites for needles gauge 22 and above. Because we are using 316L stainless steel and a lower needle gauge, we do not anticipate breakage or corrosion in the body. Silicone adhesive is shown to be one of the strongest medical adhesives. The silicone adhesive on the infusion site will not release from simple brushing of clothing or bumping a surface. Silicone adhesive will also remain strongly bonded in the presence of water and requires a harsher solvent such as isopropanol to remove. The PVC tubing for levothyroxine delivery has high kink and necking resistance. The tube will remain optimal for flow of the drug from the pump to the infusion site and will not kink or break during everyday typical actions. To measure device functionality, we'll first look at changes in TSH concentration. A lower concentration would indicate that levothyroxine is being successfully administered and used by the body. Over time, there would be more consistent or stable measurements of TSH as the body adjusts to the dosages being given each day. Second, we would be looking at reduction of hypothyroidism symptoms. Most commonly, patients on levothyroxine notice less fatigue and more stable weight and possible reduction of visibly enlarged thyroid. Signs that too much levothyroxine is being administered would be rapid weight loss, shaking, sweating, insomnia, and restlessness.
So Ellis had already mentioned the current treatments for hypothyroidism, except for one, which is a combination treatment with PZL and levothyroxine for long-term release and thyroid hormone stabilization. Though our design is more convenient and portable, it only suits cases of hypothyroidism that result in an increase of TSH levels. The needle is minimally invasive compared to just taking a tablet each day, and the patient could have an error. Moving on to assays and experiments, we plan on doing a variation of biocompatibility testing on the different components of our device. Cytotoxicity testing will be done on the needle, the tubing of the pump, and the adhesive to ensure there are no leachables that will be harmful. Sensitization assays will be done for the needle and the adhesive, since both will be in direct contact with the skin. Hemocompatibility and corrosion tests will be done on just the needle, since that is the only metal material that will be in contact with blood. And lastly, degradation tests will be done on the needle and the tubing of the pump to ensure the degradation products are not harmful if there are any. The standards for the testing methods are listed on this slide, and I'm going to go into detail for each of them. For cytotoxicity, MTT assay would be done by direct contact, which is both quantitative and qualitative, and this will be done to measure cell proliferation and viability. This method has high accuracy at detecting cytotoxicity and is the most common method. Disadvantages include that it does not determine the specific cause of cellular death, and it may underestimate cellular damage and only detect death at the last stage. Local lymph node assay is a quantitative method that would be done to measure lymphocyte production, and that would occur if the body is having an immune response against the materials. This test can provide dose-responsive data and can predict potency. However, it is difficult to pinpoint what would be causing a positive result for sensitization, whether it be a particular molecule or an interaction between molecules and proteins. Corrosion tests are quantitative and would be done to measure the amount of ions in an electrolytic solution that the needle has been in for a month. This test would be done to ensure that the material resists corrosion between patient needle changes. Degradation tests are quantitative and are necessary for new medical devices. This information must be presented for any medical device that has potential for degradation in the human body, and that's according to the ISO standard. An in vitro test will be performed to determine the rates of degradation and the release of any toxins of our device. Hemocompatibility testing will be performed on a system that most mimics in vivo conditions of a hypothyroidism patient, and this will test thrombosis, coagulation, platelets, hematology, and complement. A main challenge of this would be to make sure that the experimental system is fully accurate and mimics body conditions. Biofunctionality monitoring validates levothyroxine delivery and ensures continuous TSH monitoring. A limitation of this is that it can take up to a month for symptoms of hypothyroidism to fade, and because of this, TSH monitoring is crucial to knowing that the device is working correctly.
All components of our device, including the needle, tubing, and adhesive, would be sterilized by ethylene oxide or ETO gas sterilization. ETO gas sterilization uses a combination of specific ETO gas concentration, temperature, pressure, time, and humidity. This type of sterilization is ideal for our device as the design includes polymers which cannot survive other sterilization conditions such as high temperature sterilization and UV sterilization. The sterilization of each component would be compliant with FDA regulations and the standards listed here on this slide. For our in vitro model, we will be using the biocompatibility testing, which Erin went over earlier, as well as pituitary and thyroid cell assays. We chose mice to be our in vivo model because other studies on levothyroxine have used mice as their animal model, and we would also monitor the human response after implantation in the clinical trials. One limitation of both the in vitro model and in vivo model is that it is difficult to reproduce the exact conditions happening inside the human body. So in vitro, it's not in any living system in mice, it's not a human body. As for our efficacy, in order to move on to the clinical trials, the in vitro models must pass the biocompatibility test described earlier, which means they cannot be cytotoxic, cannot corrode or degrade during the time it spends in the body, cannot cause a sensitization or allergic reaction, and must be hemocompatible. The animal models must not demonstrate an overabundance of TSH hormone, and they must also demonstrate a reduction of hypothyroidism symptoms, which may be observed as less fatigue or less weight gain.
So on to the clinical trials. There will be 4 phases. The first phase will include 20 to 100 individuals, will last up to several months, and this is for safety and dosage testing. Phase 2 will include several hundred patients, will last up to 2 years, and will test for efficacy and side effects. Phase 3 will include 300 to 1,000 individuals roughly, and will last approximately 1 to 4 years, and this is for efficacy testing and monitoring any adverse reactions. Finally, phase 4 will include several thousand patients and will be for monitoring for continued safety and efficacy. So here's a list of all of our references. Thank you all so much for listening. We are looking forward to answering your questions in class. Thank you.